Ultrasound assessment of fluid responsiveness via LVOT VTI. Good morning, colleagues. Today, I'd like to discuss a precise and valuable tool in our hemodynamic assessment arsenal, the use of left ventricular outflow tract velocity time integral, or LVOT VTI, to evaluate fluid responsiveness in our patients. Why use LVOT VTI for assessing fluid responsiveness? Determining which patients will benefit from fluid administration remains one of the most challenging aspects of critical care medicine. Traditional static measures like central venous pressure and pulmonary capillary wedge pressure have proven unreliable. Even physical examination findings can be misleading, particularly in complex cases. LVOT VTI offers several distinct advantages. 1. It directly measures stroke volume, which is the fundamental parameter we're trying to augment with fluid administration. 2. It's non-invasive, reducing iatrogenic complications associated with more invasive monitoring. 3. It allows for real-time, repeatable measurements that can guide minute-to-minute clinical decision-making. 4. It provides a continuous variable rather than a binary outcome, allowing for nuanced interpretation within clinical context. The LVOT VTI represents the distance that a column of blood travels during ventricular systole. Since the cross-sectional area of the LVOT remains relatively constant in a given patient, changes in VTI directly reflect changes in stroke volume. This makes it an ideal parameter for assessing fluid responsiveness. Locating and measuring LVOT VTI under ultrasound. To accurately measure LVOT VTI, follow these steps. 1. Obtain an apical 5-chamber view. Position the patient in left lateral decubitus position if possible. Place the phased array transducer at the apex of the heart, typically the point of maximal impulse, with the indicator pointing toward the patient's left side. 2. Optimize the image. Adjust depth and gain to clearly visualize the left ventricle, left atrium, and LVOT. The LVOT appears as the connection between the left ventricle and the aortic valve. 3. Apply color Doppler. This helps identify the direction of blood flow through the LVOT and ensures proper positioning for the subsequent pulsed wave Doppler. 4. Position pulsed wave Doppler, sample volume. Place the sample volume in the LVOT, approximately 0.5–1.0 proximal to the aortic valve. The sample volume should be aligned parallel to blood flow to minimize angle error. 5. Obtain the spectral display. The resulting waveform should be a smooth curve with a rapid upstroke and more gradual downslope. Optimize the scale to maximize waveform size without clipping. 6. Trace the velocity time envelope. Most modern ultrasound machines allow for automated or semi-automated tracing of the velocity time curve. The area under this curve is the VTI, measured in centimeters. 7. Average multiple measurements. To account for respiratory variation, average 3 to 5 consecutive cardiac cycles in spontaneously breathing patients. In mechanically ventilated patients, measurements should be taken at the same point in the respiratory cycle. For LVOT Vmax, peak velocity, simply record the highest point of the spectral Doppler waveform rather than tracing the entire envelope. While Vmax is easier to obtain, VTI provides a more comprehensive assessment of stroke volume. The passive leg raise, PLR, method. The passive leg raise test is an elegant, reversible fluid challenge that transiently increases venous return by mobilizing blood from the lower extremities to the central circulation. Here's how to perform it. Timing and steps of the PLR method. 1. Baseline measurement. With the patient in semi-recumbent position, head elevated approximately 45 degree, obtain baseline LVOT VTI measurements. 2. Perform the maneuver. Without disconnecting monitoring, lower the head of the bed to flat and simultaneously raise the patient's legs to 45 degrees above the horizontal. This can be achieved using an automated bed or by manually adjusting the position. 3. Timing is critical. The hemodynamic effects of PLR occur rapidly, typically within 30–90 seconds, and may be transient. Measurements should be taken at maximal effect, usually around 60–90 seconds after position change. 4. Return to baseline. After obtaining measurements, return the patient to the semi-recumbent position and confirm return to baseline hemodynamics. Cutoff values for the PLR method. An increase in LVOT VTI of 10–12% following PLR strongly suggests fluid responsiveness. Some studies suggest that an absolute increase of 12% has the best predictive value, with a sensitivity of approximately 77-85% and specificity of 82-90%, depending on the clinical context. The beauty of the PLR test is that it serves as a reversible fluid challenge. If a patient demonstrates an increase in LVOT VTI with PLR, they are likely to respond similarly to actual fluid administration. If they don't respond to PLR, we can avoid unnecessary fluid administration. The Trendelenburg maneuver. The Trendelenburg position, TP maneuver, involves placing the patient in a head-down position with feet elevated, typically at a 15-degree downward bed angulation. Like PLR, this maneuver temporarily increases venous return to the heart by shifting blood from the lower extremities to the central circulation, effectively serving as a reversible fluid challenge. Timing and steps of the Trendelenburg maneuver. 1. Baseline measurement. With the patient in a supine position or with a slight upper body elevation of 15 degrees, obtain baseline LVOT VTI measurements. 2. Perform the maneuver. Adjust the bed to a 15-degree downward angulation, ensuring the patient's head is lower than their feet. 3. Timing is critical. Hemodynamic measurements should be taken approximately 1 minute after position change, as this is when the maximal effect typically occurs. 4. Return to baseline. After obtaining measurements, return the patient to the baseline position and confirm return to baseline hemodynamics. Cutoff values for the Trendelenburg maneuver, research by Ma et al. 2021, demonstrated that an increase in LVOT VTI of just 10% during the Trendelenburg maneuver predicts fluid responsiveness with high reliability in cardiac surgical patients. Their study showed a sensitivity of 100% and specificity of 70% at this threshold, with an impressive area under the receiver operating characteristic curve, AUC, of 0.90. Importantly, this same research found that changes in peak velocity, Vmax, during the Trendelenburg position were poorly predictive of fluid responsiveness, with a significantly lower AUC of 0.72. This finding suggests that VTI is a more reliable parameter than Vmax for this assessment. Respiratory variation in LVOT. VTI respiratory variation in LVOT. VTI offers another dynamic assessment of fluid responsiveness, particularly useful in mechanically ventilated patients without spontaneous breathing efforts, measuring respiratory variation. Wassertonen 1. Record multiple cardiac cycles. Obtain continuous LVOT, VTI measurements spanning at least one full respiratory cycle, typically 4-6 cardiac cycles. 2. Identify maximum and minimum values. Determine the maximum and minimum VTI values within the respiratory cycle. 3. Calculate variation. Use the formula variation, percent, harm, maximum VTI, minimum VTI, mean VTI, x 100%, cutoff values for respiratory variation. A respiratory variation in LVOT, VTI exceeding 12 to 15% predicts fluid responsiveness with high reliability. This approach has demonstrated a sensitivity of approximately 75-80% and specificity of 85-90% in mechanically ventilated patients. Importantly, respiratory variation is most reliable under specific conditions. Regular cardiac rhythm, controlled mechanical ventilation without spontaneous efforts, tidal volumes of at least 8 minolakilits predicted body weight, normal chest wall compliance, absence of right ventricular dysfunction, pros and cons of using LVOT VTI for fluid assessment advantages. 1. Direct measurement. LVOT VTI directly reflects stroke volume, the parameter we're trying to optimize. 2. Non-invasive. Unlike pulmonary artery catheterization, it carries minimal risk. 3. Repeatable, can be performed serially to assess trends and response to interventions. 4. Widely available. Most modern ICUs and emergency departments have access to the necessary equipment. 5. Physiologically sound, based on well-established principles of cardiovascular physiology. 6. Superior to peak velocity. Research has demonstrated that VTI is more reliable than peak velocity, Vmax, in predicting fluid responsiveness. A 2021 study by Ma et al. Found that while changes in VTI during the Trendelenburg position had excellent predictive value, AUC 0.90, changes in peak velocity were significantly less reliable, AUC 0.72. Limitations. 1. Technical expertise required. Accurate measurement demands proper technique and experience. 2. Image quality challenges. Not all patients have adequate acoustic windows, particularly those with obesity, COPD, or chest wall deformities. 3. Time intensive. Proper positioning and multiple measurements require time that may not be available in emergent situations. 4. Poor reliability in arrhythmias. Irregular rhythms like atrial fibrillation make interpretation challenging. 5. Not validated in all populations. Less reliable in spontaneously breathing patients or those with certain cardiopulmonary conditions. Pitfalls in LVOT, VTI measurement. Several factors can lead to inaccurate assessment. 1. Improper angle of insonation. Doppler measurements are angle dependent. Angles greater than 20 degrees can significantly underestimate velocities. 2. Inconsistent sample volume placement. Small changes in sample volume location can yield dramatically different measurements. 3. Respiratory interference. Failure to account for respiratory variation can lead to erroneous conclusions, especially in spontaneously breathing patients. 4. Aortic valve. Pathology. Stenotic or regurgitant aortic valves invalidate the assumption that LVOT VTI accurately reflects stroke volume. 5. Variability in LVOT diameter. Measurement. If calculating absolute stroke volume, small errors in LVOT diameter measurement are magnified when calculating area, R2. 6. Dynamic LVOT obstruction. Conditions like hypertrophic cardiomyopathy or Takotsubo syndrome can cause dynamic obstruction that confounds interpretation. 7. Vasoactive medications. Changes in vascular tone from medications can alter the relationship between LVOT VTI and effective tissue perfusion. 8. Reliance on peak velocity. Instead of VTI, research demonstrates that peak velocity, Vmax measurements, are less reliable than VTI for predicting fluid responsiveness. The study by Ma et al. In 2021 found that during the Trendelenburg maneuver, changes in peak velocity showed poor predictive value compared to VTI. Peak velocity measures only a single point in the cardiac cycle, whereas VTI integrates the entire systolic flow profile, making it a more comprehensive assessment of stroke volume. 9. Patient position considerations. When using position change maneuvers like the Trendelenburg position, ensuring proper and standardized positioning is crucial. The study by Ma et al. Utilized a precise 15-degree downward bed angulation for 1 minute, with measurements taken at specific times. Conclusion. LVOT VTI assessment, combined with dynamic maneuvers like passive leg raise, provides a powerful, physiologically sound approach to evaluating fluid responsiveness. When properly performed and interpreted within the appropriate clinical context, it can guide fluid management decisions with greater precision than conventional static measures. However, like all clinical tools, it must be used judiciously and with full awareness of its limitations. Technical expertise, appropriate patient selection, and integration with other clinical data remain essential. By mastering this technique, you add a valuable tool to your hemodynamic assessment arsenal, one that can help navigate the delicate balance between insufficient resuscitation and harmful fluid overload. Thank you for your attention, and I am Dr. Chen. See you next time.